And all right, everything's working. Okay, here we go. So let's dive in. So this is where we stopped last time. We were talking a little bit about phase 1 treatment in general and how we diagnose and look at these cases together. So before we jump in too heavy on this case, like what are some things, what are some diagnoses when you look at this patient? What are some of the things that stand out to you? What do you see?
Anterior crossbite.
Okay, you have an anterior crossbite. All right. So, you know, everybody in this room understands what it means when we say anterior crossbite. But if you tell a parent or a kid that, oh, you got an anterior crossbite, they're probably just going to be like, oh, that's cool. Right? So what does an anterior crossbite mean? What does it mean?
High chance of trauma.
Okay. What kind of trauma?
Avulsion, if they were to hit their face.
Okay, could possibly, yeah, like for instance, if it was causing a slide eccentric, right, and their teeth were really hitting heavy and then they slide one way or the other, yeah, if you slam down on those teeth, absolutely, one could fracture off. All right, what other kind of trauma could it cause? Yeah, it could definitely cause attrition, right? So when we look at this area here, you can see that every time they bite and chew, those teeth are rubbing up against each other, so that could cause attrition for sure. What other kind of trauma could it cause? What's that?
Gingival trauma.
Okay, gingival trauma. Tell me more. What kind of gingival trauma? Recession where?
On 25.
Yes, on the lower right one, as us orthodontists call it. So yes, we could have recession here. And why would you have recession here? Why would that happen?
The tooth ate or the right one.
Yeah, the tooth flares facially, and once you run out of bone, you know, all you have is gingiva, right? And then if they, you know, brush the gingiva too hard and or if you just push it too far, you're going to have recession there. Okay, what other kind of trauma can you have? Or can you think of any other trauma? And I know you guys have covered a lot. Okay, so we've covered our anterior crossbite. All right, so what else do you see in this case? Okay, so if they're in an anterior crossbite, it could restrict maxillary growth. All right, so raise your hand if you agree with that statement as accepted in general. All right, raise your hand if you don't think that that's true. All right, we got a couple for that. Raise your hand if you think it's controversial. Yeah. Yeah. Okay. Yeah. So I mean, like, you think about that, right? I mean, like, so, you know, traditionally we used to do a headgear, right? Or some people still do, right? So, you know, with headgear, the idea is that you can restrict the maxilla growth to some extent, right? So by that thinking, and that's been shown, I mean, basically when they look at headgears, they do have before and afters, and basically it's a series of things that happens, right? You have a little bit of restriction of growth of the maxilla, you have a little bit of tipping, you have a little bit of uprighting the occlusal plane. There's a lot of things that goes into effect. So whether or not like an anterior crossbite with one tooth will restrict the growth of the maxilla, I don't know, right? I don't know that anybody knows. But it's a decent thought, right? I mean, because you're thinking about how the jaws relate together, and if there's something in the way, then yeah, that could potentially cause a problem. How significant is it? I don't know, but it's a good thought. So what else? What else do you see in this case? All right, look at the smile. What do you see in the smile?
He doesn't know how to smile.
Okay. And that was where this came in. I think my records tech scared him, right? So, but what else about the smile? Like, what is ideal and not ideal about the smile? What's different about this smile than what you might see in other smiles? Yeah. Okay, you see all of his lowers. What's that?
Makes him look older.
Okay, he looks a little bit older. Okay, so that's correct. You're seeing all the teeth on the lower here. All right, and so if you're seeing all the teeth on the lower, what are you seeing or not seeing on the upper? What's that?
We're not seeing most of the incisors.
Yeah, a lot of the incisor display is deficient. Now, in a young child like this, should we have deficient incisal display? What would be normal or ideal? Yeah, a little bit of gingival display, right? Because what happens as we age to our gingival display? It decreases, right? To the tune of how much per how much? You were close. About a millimeter per decade, all right? And typically starting around the age of 30, right? So we know that if we want this child to actually look youthful for any, amount of time, then there's going to be something that we need to do in order to increase the current incisal display that's happening, right? If you want to have ideal aesthetics. But why might this child's incisal display be deficient in the first place? Like, why would that happen, right? If it's not technically normal or it's not ideal, Why do you think that happened? Okay, a deficient maxilla, right? Because we know that as the maxilla is expanded, what other movements happen with the maxilla? Comes down and forward, right? So maybe that theory about this crossbite keeping the maxilla, I don't know. I mean, we have a deficient maxilla, right? I mean, it's there. We can see it, right? It has the effects on the face that we're seeing and with the bite. So I don't know. But what can we do? If we're thinking about this case from a ideal standpoint, meaning like getting the most changes possible, should we start looking at the teeth or should we start looking at the jaws as far as our diagnosis and problems go? The jaws, right? Because the jaws are something that we can change when a child is young, that we can no longer change when a child is full grown, right? So if we're looking at this case and we're thinking about, okay, what's our problem list? So one of the things that you identified as it relates to the jaws is a deficient maxilla, deficient both in vertical and potentially in AP, right? Because we have this anterior crossbite, and so like that's not normal. So the fact that this, jaw moved into crossbite easily is probably an indicator that there is a deficient maxilla in the AP as well. Now, if you take a Ceph, you can trace that out and you can confirm that. But this is where you want to start thinking. So let's talk about the lower jaw now. Is there anything to suggest that there is a problem with the lower jaw based on what you're seeing here? I got some head shake no's. I'm not like, you look at his profile, right? I mean, are you seeing anything like crazy weird about his profile for that age? You can look at his, chin, throat, neck length here, right? I mean, that looks pretty normal for a kid that age. It's not like super short or extra long. And so like, from a mandibular standpoint, certainly from this view, I'm not really seeing a ton that would say like there's a big problem in the mandible, all right? So once you have your, maxilla and mandible problems figured out, well, then we can dial that back into, okay, well, now what do we need to do with the teeth? So let's talk about like if we were to treat this child and we were to expand that child, that would start to address the underlying maxillary skeletal issues that we've seen, right? So we can expand. And again, in the posterior, you guys didn't mention this, but do you think this child needs expansion in order to achieve an ideal result in occlusion one day? Do you think this child needs expansion? Yes or no? So raise your hand if yes. Okay, raise your hand if no. All right, we got more no's than yeses. Okay, so I'm going to side with the yeses on this one, and here's why. So look at the dentition of the lower arch. What do you notice about that lower arch dentition? Yeah, it's tipped in, right? What do you notice about the upper dentition? Yeah, it's tipped out, right? Now, ideally, when you look at our literature, we want those teeth to be upright within the bone, specifically the roots, right? So our goal to get to the most ideal occlusion possible is to have a patient in class 1 occlusion, canine and molar, and having those roots upright within the bone. In order for those teeth to be upright within the bone, how large do the jaws have to be in relationship to one another? Yeah, the upper has to be 3 to 5 millimeters wider than the lower. And why does the upper have to be 3 to 5 millimeters wider than the lower? Yeah, because the upper teeth are supposed to have buccal overjet, right? They fit on the outside of the lower teeth. And so when we look at a patient who already has compensations, now, is it possible that we could not expand and get the teeth to fit together? Absolutely. Right? We do it all the time, right? Patient may not want expansion, or maybe they don't have the opportunity, or maybe they come in when they're past that age and it would be too aggressive to expansion, or they don't want to do it. We get teeth to fit together in the absence of ideal jaws all the time. But we always want to start out with the most ideal result possible. So when we see dentition that's tipped inward and on the bottom and tipped outward on the top, the first thing we want to think about is, well, can we move the jaws to help correct that? And in this case, we can. And now with cone beam, which I didn't have at the time when this case was done, you can actually measure those discrepancies out. But in order to measure them, you also have to know what's going to happen normally from a growth standpoint within the maxilla and the mandible, right? So tell me this, and I don't know the exact age. I have to look up the exact age of this patient. But let's, for argument's sake, just say this patient is 7 years old, okay? So if this patient is 7 years old, how much is their maxilla going to grow from a width standpoint between that time and the time they're done growing? 4 millimeters, absolutely right. And how do we know that? Yeah, historically, most notably probably the Iowa growth study, right? All right. So in order to determine how much expansion we need, how much orthopedic expansion we need, how much change of the maxillary bones we need, we have to know how much change of those maxillary bones we're going to get on our own. right? So that way when we're measuring between the middle of the basal bone on both the maxilla and the mandible and we're comparing those things, we know where that needs to be in order to get it to ideal, all right? So let's just say for simple math's sake, the patient's 7 years old and their upper jaw is 1 millimeter wider than their lower jaw. Do you need to expand orthopedically? No, right? Because growth is going to take care of that for you, right? In the vast majority of, assuming they grow normally, right? So let's take a situation then where the upper jaw is 5 millimeters smaller than the lower jaw at 7 years old. All right? How much orthopedic expansion would you need in order to correct that? 6 millimeters, right? So if you need 6 millimeters of orthopedic expansion, right, change of the bone itself, how are you going to achieve that with a traditional type of expander on a 7-year-old? How much are you, let me ask that a different way. How much do you think you're going to have to expand that expander in order for the net result to be 6 millimeters of bony change?
Much more than 6 millimeters.
Okay, yes, more than 6 millimeters, but how much more?
Probably going to get like 40% tipping, right? Or 50% tipping.
40 or 50% typically?
No, tipping with the teeth.
Okay, 40 or 50% tipping, so 50 to 60% skeletal, all right, in a 7-year-old. I would agree, right? So you look at the research, all right, you do like some type of good anchorage expansion, right? If you do some type of good anchorage expansion, RPE type expander, when I say RPE, I don't mean like 2 or 4 times a day, because when you look at the literature, it's been shown that you don't need that many turns per day, all right? You can turn it once a day and have plenty of orthopedic expansion. And if you have good anchorage, right, whatever you're connected to, then you should get about 60% skeletal change, all right, in a 7-year-old, all right? But what happens as that patient ages? What percent of skeletal change, what happens to that? Does it go down or up the more they age? Yeah, it goes down, right? So they get a little bit older. And why does it go down? Why is the skeletal change less as the patient ages in general? What? What's that?
The bone gets more dense.
What bone gets more dense?
Suture.
Yeah, well, I mean, and I wouldn't think of it as much in density as I would in maturation of the suture, right? So, I mean, like there might be some studies that show the actual density, but what we know and what's well established is that the interweaving of the maxillary suture will continue to increase as the child ages. And so if you're increasing the interweaving of the maxillary suture, what's increasing from the math formula, right? What part of that's increasing if that's, it starts with an R and it's, resistance, right? So the resistance is increasing as the child gets older, right? So the amount of skeletal change and expansion that we're going to achieve is a direct function of the resistance and what else? Starts with an A, longer word. And A-N. Yes, an anchorage, right? So we have anchorage and we have resistance. So the older the child gets, the resistance increases. So if you want to obtain the same type of expansion or you need better expansion or more expansion in an older child, what are your options to get more orthopedic expansion? Yeah, more anchorage, right? Because, I mean, there's not really a great way to decrease the resistance. I mean, you could. I guess you could go in there with like a piezotome, but I would never recommend that. You're totally disrupting the natural growth of the patient, right? That suture's still maturing. If you go saw through it in a growing patient, I mean, I don't know. I can't think of a good justification to do that. So decreasing the resistance is not really an option in a growing patient, right? Or at least not a good option in my opinion. So you have to increase the anchorage. So how do you increase the anchorage? TADs are one way, right? So that's the way that I do it most commonly now because it's a very simple way, all right? So if you increase the anchorage with TADs in a growing patient, what percentage of orthopedic expansion might you expect to get? Or let me ask that a different way. From an ideal standpoint, if you expand the upper jaw with TAD anchorage, all right, assuming that you have good TAD anchorage, right? You have bicortical engagement. You're placing these TADs in locations where there's, 2 plates and the bone is thicker. Assuming you have good skeletal anchorage with your TADs, what percent of orthopedic expansion can you expect to achieve with bone-anchored expansion in a growing patient? We said 60% in the 7-year-old. So let's just throw out, let's just say a 14 or 15-year-old. What percentage of skeletal orthopedic change can you expect to achieve with bone-anchored expansion? Really, really close. Yeah, about almost 90%. So, and this is the most recent study that came out last year. Dr. Moon and his group did a study with the MSc on growing patients, and they demonstrated approximately almost 90% of true orthopedic expansion. And the remainder of the expansion being dental tipping and dental alveolar bending, right? So never in our history have we been able to affect that much orthopedic change in patients as we have been able to by increasing our anchorage by adding TADs to a system. So let's get back to this patient here, and we'll see. Now, obviously, he's young, so we don't need that much anchorage to get the change. But actually, before I ask you that, let's say TADs are out of the question. So let's jump back 15 years ago or 20 or whatever it was, and you still have that 13, 14, 15-year-old patient. What else can you do to get more skeletal change? Yeah, a Haas can increase the anchorage, right? If you do the Haas, then you have the palatal shelf, so you're pushing on the palate as well as the teeth. Absolutely, you can increase the anchorage that way. Definitely worth considering. Now, who here has done a Haas? tell us about a Haas. What?
You do it a few times and you realize you don't want to do it.
Right. Yeah, it becomes a patient management, headache, right? They can get inflamed, they can have pain. You can pull the Haas out and you can see palatal bone. That's fun. So yeah, there's a lot of things that can go wrong with the Haas, but it's a good thought, right? You increasing the anchorage some other way. All right. So what else can you do? Let's keep going.
You can band the fours as well.
You can include more teeth. All right. So we talked about palate. We talked about teeth. All right. What else can you do? Tell me more. Okay. I mean, in essence, headgear is essentially you have to categorize that in a way with the teeth if you're talking about a purely expansion standpoint, because if you're putting headgear in and you're hooking it to the headgear tubes and you're expanding, you're really just putting more force on the teeth, right? So that it doesn't really increase the anchorage, it just increases the force on the teeth when you're talking from an expansion standpoint. All right, but what else can you do to if you need 6 millimeters of bony change and the patient is older and you're not going to get 60% orthopedic change, how do you get that change? What do you have to do? Surgery. Well, you could wait till you could do surgery. All right, you got to expand more, right? And like if you're only getting 50% skeletal anchorage or 40% skeletal anchorage, well, now you got to turn that expander to 12 millimeters to get 6 millimeters orthopedic, right? Now, at some point, that becomes not so effective because again, you get back to the complications being worse than solving the problem, right? But I mean, the older they get, if you're not using bone anchors, the more expansion you have to do with the screw in order to get that change. Then you have to hold it there, right? And you have to let the bone fill in, and then you have to deal with whatever dental complications you created by expanding, which in a case like that is going to be severe dental tipping and dental alveolar bending. The dental alveolar bending, I mean, I'll take that. That's not terrible, right? At least it keeps the bone around the teeth. The dental tipping, that's no fun. That's when you get into cases where buccal molars are pushed outside a bone, and so it's something that you want to consider. All right, so let's go back to our case here, and let's look at the panel here. So what do we see in the panel? What stands out to you? Right. What about the canines? Yeah, they're pretty high up there. All right. So the canines are high. So what does that mean to the patient and the parent? Like what's important about the canines being high? You already mentioned one thing, impaction. All right. But what does impaction mean? What does that mean for the patient and parent?
Teeth might not come in, root resorption.
Okay, so root resorption is another thing. So we're going to back up from root resorption, go back specifically to impaction. What else does it? But it is a function of impaction. What else does impaction mean for the patient? You mentioned the teeth might not come in. What else does it mean? Yeah, it means they might be setting them up for surgery, right? If the tooth doesn't come in, they're either going to have. I mean, I guess you could leave it in some cases, but most of the time you're going to do what? You're going to surgically expose it, right? If you go to surgery to surgically expose a tooth, what's likely going to happen to the patient during that procedure? Are they going to be awake or asleep? Right. Is being asleep a risk-free procedure? No, right? I mean, do kids die from being put to sleep every year? Yeah, absolutely, right? So again, when you say, oh, it's impacted canine, that doesn't mean that to the parent, right? They don't understand what you understand about impacted canines, right? So when you're explaining this to them, you have to tell them what it really means. And why do you have to tell them what it really means? Why is that important? Why do they need to know? So they're informed, right? They understand the risk. That's informed consent. Because if you say, oh, you just have an impaction, we'll deal with it later. Is that informed consent? No, because they don't understand what you understand about impaction, all right? So we know that if they have an impaction, that's most likely going to be a surgical procedure, which carries a significant amount more risk than possibly some of the other interventions that may be possible before then. What's that? Money. Yeah, money, time, everything. And then what else can happen with surgical exposure of canines? Will your final result always be the same? No, it might not. And if it wasn't the same, would it be better or worse? Yeah, most likely worse. And why? What are some things that can come up with our impacted canine cases? For long term, right? The final result, when you're all done with orthodontics and everything, what are some things that often happen with impacted canines? Yeah, you have recession, right? So if they're exposed to the buccal, right, some of the bone may go away. It may not follow as the tooth is brought down. You may have long-term recession problems, all right? So there's a number of things. Could the tooth itself be damaged during the exposure procedure, right? Yeah, it could be chipped, could be, hit with the burr, could nick the CEJ. I mean, there's a lot of things that could happen as they're removing bone around the tooth, right? So you might be working with a less than ideal result at that case. Again, so does that mean that the parent has to do what you're recommending now? No. We inform them of what's likely to happen if they do what we're recommending and what's likely to happen if they don't. So back to our impacted canine scenario, we mentioned the what's going to happen to correct the impaction. We also mentioned that there could be root resorption, right? And what does root resorption mean to the patient?
Damage to adjacent teeth,
Okay.
potential loss of adjacent teeth.
Okay, yeah, potentially lost. That's probably the biggest one, right? So if they have root resorption, they might lose that tooth. If they lose that tooth, what's likely going to be needed later? Yeah, possibly an implant, right? Or a lot of aggressive orthodontics to try and make it look better or mesialize a bunch of stuff. But a significant amount of procedure. And if they need an implant, that could potentially carry more risk as well, depending on who's doing it and how they do it. And is an implant as good as a normal tooth? Yeah, I mean, it doesn't seem like they are. I mean, we don't know how long implants are going to last. I mean, they really haven't been around hundreds of years, right? I mean, it seems like they're stable. It's like the best thing we have at the time. But what's the other impact, especially as it relates to a child and losing a tooth early? What's a big part that's going to happen during their formative years if they lose an important tooth like a lateral or a central? Tell me more about that.
Like being self-conscious of it or bullied or things like that.
Yeah. Can they get an implant when they're 10? Yeah, or 12 or 16? High school, middle school, out of the question. So they're going to have some type of other something in there, whether it's a flipper or an Essex with a fake tooth in there. Or maybe, like if they can afford it, maybe they'll get a nice like one-wing Maryland bridge, all right? But then that can break too, right? So a lot of potential things can come about from root resorption. And they don't understand that, right? Oh, root resorption, all right, so it might dissolve the roots of the teeth a little bit. Okay, well, that should be fine, right? The tooth will just come in later and everything will be fine. No, they don't understand it the way that you do, so you have to explain that to them, okay? So what else, and this is the third thing, whenever we talk about crowding in the maxilla, we talked about impaction, we talked about root resorption. What else might this child experience if we don't intervene and do something about the situation now that might affect them later? Yeah, you might have to pull premolars to get these teeth in if you don't have enough space, right? So if there's not enough space within the jaws, then you might have to pull premolars, right? And then what does that do long term? Okay, so I mean, this is where we get a little bit controversial, right? So I mean, you look at a lot of the historic orthodontic research, and they'll tell you like, there's no definitive correlation between extracting premolars and TMD. There's no definitive correlation between extracting premolars and sleep disorder breathing. But and they also say that there's no definitive correlation between extracting premolars and facial profile. Okay, if you talk to a lot of orthodontists, they don't agree that that's entirely true. And the reason for that is their own experience. Now, will the research ever bear that out? I don't know. But my guess is yes, especially now that we have three-dimensional imaging and the exorbitant amount of research that's coming out understanding how dental arch widths and skeletal arch widths affect airway and specifically sleep apnea. So in my opinion, I think this one day will be bared out in the literature. But for now, I mean, this is still like a hot topic of debate. So, if I were explaining it to a patient, I would explain it just like that. As if you look at the research, there's, you can't like point to articles that say if we extract permanent teeth, it's going to cause any major problems. But there is a lot of research that when you look at it, it makes sense. Now, most of the research that's done, when they're talking about extracting premolars, they're talking about extracting premolars in an ideal jaw size relationship way, meaning they're controlling for the amount of jaw size, meaning that if you're extracting premolars and the jaw size is not ideal, you may be excluded from those studies that say that nothing bad happens afterwards, if that makes sense, right? And in a way, that's good because in my opinion, why are you extracting premolars if that's not the problem, if the jaw size is the problem? So in a way, that's good. Another way to say that is if you extract premolars in a normal sized jaw, I would agree that you're probably not going to have a ton of problems later on. If the jaw is normal size, that means you can get the rest of the teeth to be within the jaw upright, right? And you can create a situation where although they have less teeth, it can still be healthy and stable because you're not compensating for the lack of, for the malaligned jaws with moving the teeth. You're literally just pulling teeth because there was too much crowding within a normal-sized arch. I had a patient come in last week, and they had severe maxillary space loss on one side, right? So their right side, the molar had drifted forward, 6 millimeters, almost into full class 2. The left side was class 1. The jaw size was normal, okay? So I gave them 2 options. I said, the easiest and simplest option is to extract a tooth, right? We get rid of that 5 on that side. The premolar has room to come in. You finish class 2 molar, class 1 canine. The left side's class 1, and you have a normal size arch. You move on. And I said we can correct it without extracting teeth, but it would require that we distalize, move all those teeth back, which is going to be a lot more orthodontics and a lot more work on your part. And I thought for sure they were just going to let me pull a tooth. And guess what option they decided to select? Yeah. So now I have a hard case, right? Because that's what the patient wanted, but they were informed, right? That was their choice. They understood the implications of both. They didn't want the tooth pulled. All right? That's not my decision to make, right? If it was my kid, I would have pulled the tooth, right? But they didn't want that. Okay? So we look at this case here. We know that we have a higher chance of impaction of canines, root resorption, and possibly having to pull permanent teeth later. All right? So we look at the profile here. Now we can see the ceph. What do you, without measuring this out, what stands out to you about the ceph? Good, bad, or indifferent? Okay? So yeah, looking at the top jaw again, and you can measure this out. You can measure S and A, S and B, but if you're just kind of eyeballing it and going like from here to here, like if you had to guess what the A and B was, it's probably not 3 to 5. You know what I mean? It's probably like maybe 1 or 2. All right, and if I had to guess, I would side with you, Justin, that I would agree that the maxilla is probably set back a little bit, and that adds up with the other things that we've already talked about: the deficiency in width and the vertical insufficiency, right? So if that top jaw was set up a little bit and back, then expanding would fix all those things, and it would make sense that that is our diagnosis. Again, if you want the details on it, just trace your ceph out, and you can look at all the numbers. Okay, so working through this case, what are we going to do for this patient? All right? Going back to our problem list and going back to ideally we're going to fix the jaws first. Like, what are we going to do with this patient? How do we fix the jaws first? Like, what's the first thing we need to do? We need to expand. All right. So now let's throw that out there and let's understand what's going to happen with just doing that. All right. So if we expand, what's going to happen to the top jaw? It's going to be wider. It's going to come downward. It's going to come forward. Okay. So if it's downward and forward, what does that do for our crossbite? Does it help it or hurt it? It helps it, right? If the upper jaw comes downward and forward, then the maxilla is going to be more forward, and that helps our crossbite situation. All right. What's the one other thing you definitely want to know in a patient like this that we haven't talked about yet? We would want to know that, right? We would want to ask about airway because that may affect how much we expand. Right? We may want to, like, if they were like a sleep disorder breathing patient and there was severe constriction, I would err on the side of definitely trying to get to that 5 millimeters wider point versus like maybe accepting 3 millimeters. So yes, that's important, but that's not where I was going. Yes. Okay. What kind of habits? Okay. If there's a habit going on that could persist, that might, continue to push that back, that's a good thought. Also not where I was going. What else have we not talked about? That's important. It makes a difference on how much AP correction we need or don't need. Yeah, we want to know if there's a functional shift, right? So, I don't know if there was or not. Honestly, I can't remember. I'd have to go back and look. But if this patient had a huge functional shift, does that change your treatment plan potentially? Right, yeah. Then you're pretty much for sure that when the expansion is done and the jaws are aligned, you're almost certainly not going to have to do anything to correct the crossbite. It'll probably correct on its own, right? So let's just assume, for argument's sake, that this patient does not have a functional shift, okay? And this is exactly where their teeth go together. So we expand, the jaw's wider, it's forward, it's down a little bit more. So what else do we need to do? Okay, so we disarticulate. How might we disarticulate? Okay, so well, let's talk about your expander first. What kind of expander are you using? What's that? Well, what kind of RPE? Yeah. You were thinking of a Hyrax, right? Because why? That's what you use the most, right? Yeah. But you understand the principles of expansion, right? So what other type of RPE or expander could you use that would disarticulate at the same time? Yeah, bonded RPE. All right. What else does the bonded RPE do for you that the Hyrax doesn't? I heard like 3 things. It opens the bite. Okay, so disarticulates. What else?
You get more anchored when you're holding on multiple teeth.
Yeah. So you are increasing the anchorage via increasing the stability or the anchorage around the teeth. The teeth hold the roots push up against the bone. So the more the roots have the ability to tip within the expansion that you design, the less anchorage you really have, right? Another way to say that is if you banded canine to molar, that's going to give you more anchorage than if you banded just the molars, than if you banded molars and premolars, right? You know, traditional orthodontics, we're taught like, band the molars at least and maybe band the molars and the premolars. But with a bonded RPE, you are essentially banding at least 3 teeth on each side, right? And so it's covering them in 360 degrees. Now, can those teeth tip? Sure, they do, right? But they tip as a unit, right? So the anchorage system that you're providing is improved the more teeth you can circumferentially cover, okay? All right, so we pick our expander. We want to disarticulate the patient. Why is that important?
The upper right one's not going to get a crossbite unless it has space to come forward.
Right, if they're continuing to chew and keeping that in crossbite there, it's more likely to stay there, right? We disarticulate. Just the fact of disarticulating, what's going to happen to that lower right central incisor? If we just disarticulate, if we just put some turbos on there and nothing else, what's going to happen to it? Yeah, it's probably going to come back. And why is it going to come back? Because there's nothing pushing it that way, right? Where do teeth normally go? They normally go in the middle of the bone, right? So the only time teeth don't go in the middle of the bone is when something's telling them not to go in the middle of the bone, right? So right now we have a tooth that's telling it not to go in the middle of the bone. Every time he bites down, it's pushing that tooth forward. So just the act of articulating, we would expect that lower incisor to come back a little bit, all right? Same thinking on the maxillary incisor. We would expect that to upright to some degree, especially in conjunction with moving the bones apart. When you move the bones apart, what happens to the teeth? What happens to the central incisors? Where do they go? Yeah, and they get a diastema because they're going with what? Yeah, they go with the bone, all right? So they go with the bone, then what happens to the centrals? Do they stay with the bone? No, they don't, right? Otherwise you'd have a gap forever, right? So where do they go after they go with the bone? They go back. And why do they drift back? Because there's bone there? Okay, maybe, but there's something specific that we've all learned about in dental school that helps pull them back. What's pulling them back? Yeah, interseptal fibers, right? They're like bungee cords. So, you change the bones. Yes, the teeth go with the bones, but then you have those interseptal fibers pulling those back, right? As those interseptal fibers pull those teeth back, do you think they're more or less likely to straighten out one compared to the other? More likely, right? If you pull a bungee cord between 2 things, one of them's here and one of them's there, as they go, they're going to be going more toward the middle, right? Because there's like really just one string pulling them, right? So the act of the expander itself and the interseptal fibers working on those central incisors to bring those teeth back together are going to help align those teeth. So with knowing all those things, do you think that you're going to need to do anything else besides an expander that disarticulates in order to correct this anterior crossbite? Right? Most likely not. I mean, if they do have any level of functional shift, maybe even an undetected functional shift, that's only going to help you. Lower jaw drops back a little bit, and you're in a situation where that can be corrected. So here we go. We can see here the changes. All right. So expansion alone. And you move on. Okay. So let's look at this case. How much time do we have? We got 20 minutes. Okay. All right. So let's look at this case. We're going to go through it in the same way. All right. So what do you see? Okay. You see a posterior open bite. All right. So we all know what that means. What does this mean for the patient? Okay. It's going to be harder to chew, but they said they're chewing fine. All right. So what else does this mean for the patient?
Trauma on the anteriors.
Why is there trauma on the anteriors? Yeah, you're only, if you don't have the posterior teeth heating, you're only hitting on the anterior teeth, right? So now we have a situation where we're increased for risk for trauma of the anterior teeth and or the only posterior teeth that are hitting, right? So either the anterior teeth and or the first molars, right? So the teeth that are hitting, because they don't have support in the mid-arch, are going to be more likely to have trauma, okay? What else does a posterior open bite mean? Okay, tell me more. Super eruption, tell me more. Okay, so in areas where there's normal eruption, right, and then there's no eruption seemingly here, then maybe these teeth could super erupt. Now, have these teeth appeared to super erupt? No, but it's a good thought, right? That's something that you want to check for. All right, so what else does a posterior open bite mean?
Some type of eruption issue.
What's that?
There's some type of eruption issue, something delaying eruption or missing teeth.
Okay, yeah, let's get to the root cause of why this patient has a posterior open bite. So what's going on here? Why does this patient have a posterior open bite? Okay, someone said ankylosis, right? So what's ankylosed? So lower D's and E's. All right, does everybody agree with that? All right, what else is ankylosed? All right, yeah, upper left E there, right? Okay, now, is this going to fix itself? Yeah, most likely not, right? Now, if this was your child, or if this was your patient, when would you have referred this patient? For treatment, or when would you have intervened? Yeah, and when, and how would you notice it before this stage? Because obviously it's obvious here, right? So how would you notice it before this stage? Okay, so who here looks at radiographs and can tell me if teeth are ankylosed consistently? It's a good thought. I like it. I don't look as many PAs as you guys do. So if you can tell on a PA that it looks ankylosed, like, teach me how. Like, honestly, like that's something that I found to be very, very difficult, to look at a radiograph and know whether or not it's likely ankylosed or not. So for me, that's not going to be the easiest thing to do. But what else can we do to determine if a tooth is ankylosed or not, or to catch it early? Okay, you can tap on it. Now, I thought this was voodoo science for a long time, right? But you tap on the tooth and they say, oh yeah, it sounds different. And I don't know, like, it just took me longer, I guess, to gain that feel or whatnot. But now it's like you can't unfeel it, right? I mean, you tap on a tooth, it's like, oh, you know what I mean? And it's very similar to when you tap on an implant. So if you have a patient that comes in that has implants, which I know a lot of you guys don't, or if their parent does, just be like, here, sit in the chair, let me tap on your teeth for a second. But I mean, like, you feel what it feels like when you tap on an implant. There's that distinct thud, and sometimes you hear it, sometimes you feel it, but it's different, right? And that's very similar to what you feel on an ankylosed tooth. Now, that took me a long time to develop that feel, right? In dental school, like people would show me and I'd be like, I don't get it. Like, it doesn't really seem to like click for me. But now it does. So that, I think that is a good way. But if that is not 100% reliable, then what other things can we look at?
You can see how delayed they are, like with the other teeth that are around.
Exactly.
Really delayed at all.
Exactly, right? What should happen to the occlusal plane of the baby teeth as the permanent teeth are erupting around? We have the first molars come in, and then you lose you lose one of the molars, and a premolar comes in. At what vertical level should the primary dentition be relative to the permanent dentition? Yeah, pretty close to the same, right? Because if the tooth is acting normally, it's going to continue to erupt, and it's going to continue to stay in occlusion, right? That's normal, right? So the minute you see a tooth that's not in occlusion anymore, what should be going off in your mind? Right, possible ankylosis, right? Is this tooth ankylosed? Well, now you have your initial suspicion, right? So now what can you do? You can take a PA, right? You can look at one side versus the other. You can tap on that tooth, all right? You can put a reminder in your head being like, oh, this tooth might be ankylosed. I'm going to check next time. And if it is ankylosed, what are you going to see in 6 months? Well, the same exact thing, or what are you going to see in a growing patient? What's that? Is it going to be exactly the same 6 months from now as it relates? So let's just say you saw a little step between the 6 and the E, right? Maybe like a, half a millimeter. What are you going to see in 6 months or a year from then? It'll be a bigger step, right? Because normal eruption is happening other places, right? That 6-year molar is still erupting. But if that tooth is ankylosed, it's not, right? So then you're going to see that change. Now that can confirm your diagnosis, right? So now you know the tooth is ankylosed. All right? So now it just becomes a question of how are you going to manage that? Okay? But let's look at this patient. We'll spend a couple more minutes on diagnosis, and then we'll spend the last 10 minutes going on, options for treating this patient. So we talked about the posterior open bite. We talked about the ankylosis and how to diagnose and detect that. So what else do you see in this patient that doesn't seem normal? Like what else is less than ideal? Okay, constricted maxilla. And what evidences are you seeing here that tells you that that's the case? What are you noticing? What are you observing? Okay, you have a more V-shaped arch. Okay, all right. So what else are you noticing? Okay, yeah, when you look at the buccal corridors, right, you can see quite a bit of space there. It looks narrow, right? All right. So again, getting into the slightly controversial things, what else do you notice that could indicate that maybe this child isn't sleeping as ideally as they might be able to? What about the eyes? Yeah, do you see the allergic shiners there, right? So again, I'm not an allergist. I'm not telling you to diagnose your patients with sleep apnea. What I'm saying is pay attention, right? So is that normal? Is it normal to have those little bags? No, it's not normal, right? The allergic shiners are not normal. So yeah, maybe this patient just has allergies, or maybe an undersized maxilla or large tonsils and adenoids or something else is causing this child not to be sleeping and growing possibly as well as they should. Let's just take that theory a little bit further, all right? So let's just assume that maybe there is sleep disorder breathing in this patient, right? Or let's do this. Let's say they came in with a sleep study and their child's been diagnosed with moderate sleep apnea, okay? What else are you seeing on this patient that may have confirmed or that you may expect if that were the diagnosis of a child? Another way to ask that is, what do you expect in the growth of a child that's not sleeping well? Okay, a long lower face. So are you seeing that here? Yeah, absolutely, right? You can see the shape of the face, all right? You can see the length, and when we look at the Ceph, we'll be able to see that a little bit better. But you can see a slightly downward, backward growth pattern. Look at the chin, throat, neck length of this patient compared to the patient before. It's, quite a bit smaller. Now, from a profile standpoint, if I was just looking at the profile, it doesn't stand out at me as overly, out of the norm, so to speak. But when you look at the nasolabial angle, is that more obtuse or more acute than normal? More obtuse, right? So indicating maybe a maxilla that's slightly, protruded relative to what would be ideal. All right, and then we know that the lower jaw here is set back even further, and we know that the face is elongated. So we see it in what else do we see data point here that may indicate that the face is elongated? What other thing do you see that would indicate that potentially? In this area here, right? So not huge, but a little bit vertical maxillary excess, and you see it a little bit more on this left side here, right? So, and then when we look at the lip at rest, we can look at that as well and see, how much lip at rest does she have? My guess is it's probably going to be a little bit more than the 2 to 3 millimeters we would expect. Okay, so upper jaw narrow, ankylosis of the teeth. Anything else that you guys want to talk about with this? Well, and then one other data point here. So you mentioned the V-shaped arch. What other data point or what other thing do you see as you look at the teeth that indicates that maybe the maxilla, or at least the teeth, are constricted relative to the mandible? Because we don't have posterior crossbites, right? That's what we're all trained to look for. Although, debatably we might have a little bit of one here, but that's not what I'm going for, okay? So, maybe that's crossbite a little bit. We can look at the models. I'm not sure. But what else do you see as it relates to the teeth that may indicate that the maxilla is a little bit constricted relative to the mandible? Tipping of what?
Teeth.
Which teeth?
Upper eye 6 is tipped out quite a bit.
Okay, so yeah, absolutely. And that's the side that looks, better from a buccal occlusion standpoint. The one that's more upright looks a little bit more edge to edge. Look more in the anterior. Yeah, look at this here, right? Is that a normal canine relationship? Now you can see that that maxillary canine is tipped in a little bit. But the mandibular canine is pretty upright within the bone. Again, that's not a normal relationship. So again, there's quite a few signs here when you start to look that are indicating that maybe this upper jaw is not as wide as it should be. Okay? So now let's go ahead and look at our pano. What do we see in our pano? What? Okay, we're missing, lower second premolars, or they're severely delayed, but I don't even see any type of a tooth bud forming there. So my best guess is that they're missing, right? What else do we see?
The upper left canine is impinging on the root.
Okay, we have an upper left canine that's really close to the root of the lateral incisor. Now, what do we worry about with that? We said 3 things last time. Resorption, impaction, and possible future extractions, right? So all those things are going to be going through our mind. Let's talk just for a second about resorption, all right? So if resorption were to happen, what tooth do you think would be most affected? Yeah, most likely the maxillary left lateral incisor. That's the one that it's closest to. Now, on a scale of 1 to 10, all right? 1 being like, I don't think root resorption is going to happen ever, and 10 being like, dude, that lateral's gone, all right? What number would you assign to the risk of root resorption on this patient? 6.5. All right. So tell me why you chose 6.5. So you're a little bit leaning more to you're a little bit leaning more toward resorption happening than not happening, right? What's that?
Defend it.
Yeah.
That side, the angle is where I'm leaning a little bit. And then
Okay. Well, let's talk about the
how
angle.
high up it is.
Yeah,
The
so-
angle's kind of normal, but how high it up?
Okay, so how high up is it? So what's important as it relates to the vertical? What's the most important thing as it relates to root resorption and the vertical level of the teeth? What's the most important thing? Yeah, the apex of what? The lateral incisor, the apex of the lateral incisor, and what on the canine? Yeah, the cusp tip of the canine. So we see that the cusp tip of the canine is, mid-root, right? And the apex of the lateral, although you can't see it definitively, seems to be above the crown of the canine here, right? So is that a good or a bad thing? That's a good thing, right? So it's past the biggest danger zone, right? All right, now you mentioned the angulation of the canine, which I'm so glad you did. So the angulation of the canine could be more upright, or more it could be more upright, or it could be more palatal, or it could be more, or it could be angulated more. So this one is angulated more, right? So does that tell you that this canine is likely to be more palatal or more facial because it's angulated? Yeah, it's more likely to be palatal. And when we're talking about from a root resorption standpoint, what does that mean? Is that better or worse from a root resorption standpoint? Better, right? Just think about it this way. There's tons of room in the palate and there's not on the facial, right? So when we're talking about root resorption specifically, I would much rather see a canine that's angled like this, that's likely palatal, than I would like one upright that really is not going to have anywhere to go, right? So definitely a risk of root resorption. And so now you have quite a bit of evidence already that having an upper jaw that's going to be wider is going to do good things, right? You're going to make more room for the canines. You're going to improve the relationship of the teeth, right? So they can be upright and not compensated. You're going to round out a otherwise V-shaped arch form. You're going to fill the buccal corridors. All right, so we have a lot of evidence for that. But we still have this problem with our ankylosed primary teeth and what we're going to do about it. So let's address the easier one first. What are you going to do with an ankylosed primary tooth that has a permanent tooth underneath it, like we see with the lower D's here? You're going to extract them, right? You're going to get them out of the way. What does extracting them do? It creates room. These teeth can come up. Is there any reason to think that those premolars won't come up normally if you extract those ankylosed teeth? No, right? That's what they do. Teeth erupt, right? Now, if you leave these, will those permanent teeth eventually dissolve those baby teeth in their entirety? Possibly. I mean, it could happen. But if they did, what long-term problem are you still going to have? Exactly. They're going to erupt in a lower plane of occlusion. You're still going to have this massive curve of spee. And depending on which teeth erupt first, as was brought up earlier, you might have, extrusion or hypereruption of multiple other teeth, depending on which one happened to get to the occlusal plane first. And, it can be pretty messy and hard to deal with. So in general, when we see an ankylosed tooth that has a permanent tooth underneath it, we are going to extract those teeth. So boom, gone, 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 and if you just want to help them out, gone, right? So we get rid of all those baby teeth that have permanent teeth underneath them, but we're still left with the problem. What about the teeth that don't have permanent teeth underneath them? All right, so we have the lower E's. What are we going to do about those?
Build them up when we
Okay, so let's stick with that option. So let's build up the teeth here, and then they can use them to function. Okay, so what does that do for us? Okay, who agrees that if we build those up, it holds the bone for implants down the road? Nobody? one person? Two people? Oh, you're getting a following here. Okay, all right. So who thinks that putting turbos on those teeth will not hold the bone for implants down the road? And nobody wants to vote is what it amounts to. Okay, all right. So I agree with you that it will hold some bone. All right, but what bone will it hold? Only the bone that's already there. Okay, only the bone that's already there. So contrast that with if you extract the tooth. All right, if you extract the tooth, we worry about losing what bone? What is it? You mouthed it, I think. What's that? Yeah, you worry about losing the width, right? So if you extract those baby teeth, you worry about losing the width. Yeah, you might get a knife edge ridge. If the surgeon compresses it, you're even more likely to, right? Was anybody taught in dental school to compress the ridge when you extract a tooth? Yeah, I hate that. Yeah, forget all of that you learned. All right, so you extract the tooth, you're more likely to lose the width. But you compare that patient that you extracted teeth on from a vertical standpoint only. All right, which one's going to have better vertical bone long term? What's that? Why? It does, right? As teeth erupt, what do they bring with them? They bring bone with them. That's normal, right? So as those molars and premolars continue to erupt as the patient is growing, they're going to vertically bring bone with them. But, which one's better? Is it better having a nice buccal width and having that 7 millimeters down beneath? Or is it better having a thin ridge and having that up higher? Now, if you had only those two options, I would argue that it's probably better to have the thin ridge higher because, they can split it, they can augment it. Whereas building up vertical bone in a huge defect is super, super difficult. And or putting an implant 7 millimeters subgingival is not going to be stable. Can you imagine the crown root ratio on that implant going on? So my if I only had those two options, I would extract the teeth and get as much vertical as I could, and I would extract them as early as I possibly could because the earlier you extract them, the more likely that bone is to follow. Go ahead.
Would you put an HA in there while you're doing expansion then to hold the space that's left because you already have medial drift of the sixes? So what would you do in the meantime? You would extract those and then expand, and then what would you do with the lower?
Yeah, so you could definitely put a lower leg holding arch there. It's a good thought because we have a lot of empty space and you don't want those molars to mesialize forward. Now, what if someone gets this, I'll be impressed. If you get this, you can have a prize that you won't want, I promise, but it'll be a prize. All right. So what do I wish I saw in this pano that I don't? Why? Who said it? All right. Here's your Southwest Airlines graham crackers that, from like 3 flights ago. All right. So why do I wish I saw 8s there? Yeah, and what would happen if I mesialize the 6s? What would they bring with it in a growing patient? Bone. And so now all of a sudden, now we're working with an almost ideal result, right? But we don't have 8s, right? So we're left with not as many good options. So does anybody know what's a better option than anything that we've talked about so far in this patient specifically as it relates to the ankylosis? Yeah, decoronation, right? Does anybody know what that is or how it works? All right, so someone tell me about decoronation. What happened? Decoronation really means remove the crown, right? All right, so what does it do? Well, back to your point. Does it maintain the buccal bone? Yeah, so it maintains the width. All right, but what else does it do? Yes, but only if the procedure is done correctly. And how does that procedure need to be done? What's the most important thing that needs to happen in order to make sure that what you just mentioned and the vertical bone growing up actually happens? You need 2 millimeters of the tooth and enamel and root removed below the crest of the bone. Okay? Otherwise, the body thinks there's still a tooth there, and it's not going to tell the bone cells to do bone. It's like, no, that's tooth there. Don't do bone there, right? You've got to get the tooth 2 millimeters below the bone. So let's look and see in this patient what happened, okay? Now, just a quick aside, we don't have time, so we're not going to go through this in detail, but now who thinks the maxilla and the mandible are retrusive, right? Sometimes when you see the ceph, it looks a little bit more obvious. Now who thinks this patient is a vertical grower, right? I mean, you can kind of see the mandibular plane angle, you can see the extent of the chin, throat, neck length, right? So having a ceph, having good imaging, you can trace all that out, is helpful in your diagnosis. All right, so what are we going to do in this patient? We talked about expanding. We can't get into the details of how we would design that expander, but what's something that could be a little bit unique in this case that you might actually consider using to increase your anchorage that otherwise you wouldn't? Yeah, you've got a tad in their mouth, right? You've got skeletal anchorage, ankylosed upper left E. If you can incorporate that, maybe build that up or something, bond to it, I mean, that's a great anchor. All right, so when you're talking about getting expansion, maybe you leave that in there for the 4 months it's going to take you to expand and then extract it afterwards, okay? But let's look at the coronation procedure, all right? So this is the explanation, maybe, if it plays. Oh, well, it didn't play. So Google decoronation on YouTube. You'll find this video, and it was made in the 80s, but it explained it. I don't know why the volume's not working, so whatever. But it talks about how the bone goes away, ankylosed, blah, blah, blah. All right, this is decoronation. All right, look at the photo on the left here. Look at the photo on the right. You can see that vertical level of bone that's happened. And to your point, look at that. They added that lower lingual holding arch, although they debatably added it a little late. All right. So, but look at this patient here. We sent the patient for decoronation. What happened? At least on one side they didn't, right? And so then I sent the patient back and I said, please redo it, but take it down 2 millimeters below the bone. This is fast forward, right? So we see that the left side acted normally. You can see that vertical growth of the bone. We did not add our lower lingual holding arch. We get an A- on this case. But look at the right side. At this point, I said, no, you got to go in there and remove that bone. And they just removed the tooth, right? And so when you look here, better solution, remove the clinical crown about 2 millimeters below the crestal bone and leave the ankylosed roots in the bone. And so we sent them off, and the surgeon sent them back, and that's how they came back, right? So again, you can't, that's why it's so important to work with people that you can trust, and I just, for the final thoughts for today's session is work with people you trust, right? So I would tell you that the #1 source of stress, angst, pain, emotional hardship in practice has been the result of working with people that I couldn't trust. And it's hard because when you're in a practice, there's so many factors that are pulling you, right? So you have a patient that comes to you, all right? Maybe they come to you, but maybe they have a dentist that you don't trust, right? What do? The patient needs good care, right? They need what you have to offer. You feel like you can treat them well, but you're going to need to work with somebody that you don't trust, right? What do? It's a situation that you're going to have to answer for yourselves every single day when you get in practice. So think about it. I mean, I don't know what the answer is. I mean, I try my best to educate the patient honestly. I try my best to never throw anybody else under the bus. But it's hard, right? Because you're going to see malpractice in your practice. You're going to see things that come through, and you're like, this should never have happened. Should never have happened, right? And you want what's best for the patient. But is the best thing for the patient to say, oh, your dentist sucks, man, and you should take him to the board, and I mean, I don't know. I mean, maybe if you saw enough of them from the same dentist, but, that's not going to make them feel any better. It's not going to improve the situation, and so it's hard. But just discover who you are as a practitioner, discover what you want, discover what you feel like is best for your practice and your patients, and work with people who you can support each other in obtaining that. All right, till next time.